we work with the advanced cancer care patients over at the PA hospital. There's a new set of therapies that are used in cancer, and you might have heard of some of them. Herceptin in breast cancer, rituximab in leukemia, and the one we really focus on is cetuximab. It's used now for head and neck cancer, especially in advanced cancers. It was a very new drug, and it works. It's the first drug in 20 years to work, but it only works for 20-30% of our patients. And for the rest, it's very expensive. It gives them significant side effects with no benefit. And so we're working to do two things. We're trying to predict which of the patients will respond to the therapies. That means that the patients that aren't going to respond don't lose time being treated by something that they're not going to have a response to and have those side effects, and they can be offered something else instead. And also we're trying to work out what the response is in the patients where it does work, and basically spread that to all the patients so that they can all respond. My lab began by developing a completely novel assay. We image what happens to the target of the drugs in the human tumours while the tumours are still alive. So the patients very kindly and bravely consent to giving us samples. We get live tumour samples from the patients, and we literally run across the road from the hospital, and we do experiments on those to look at what the target of the drugs is doing in these patients. When we started that, none of this had ever been looked at before, none of it was known. And what we found is that in the patient tumours, in some of the patients, the target of the drug gets stuck on the surface of the tumour. Now, in a normal case, what happens is the drug binds and the cell basically eats its target and the drug. But in these few patients, the drug and their target was stuck on the plasma membrane, which is the surface of the tumour cells. And so when we looked at the outcomes for these patients, we realised that it was those patients who were actually doing well on the new therapies, which is almost the opposite of what we would have predicted to start with and what the theory was. So then we decided to use some small molecule drugs, which make the target it basically makes it stuck in the plasma membrane. And so what we're trying to do is turn those patients who don't respond because the receptors in the drug get eaten by the cells into the patients that do respond, which are those where the targets get stuck on the surface of the tumour. And so we've tried this in the lab with these new small molecule compounds, and not only do the tumour cells that die in response to these drugs go from maybe 40% death up to 80%, but also the tumour cells we have that are completely resistant to this drug now die in response to treatment. And so we've got 2 patents on this. The first is to use our imaging assay as a way to predict which patients should get the drug and which patients shouldn't. But also this accidentally almost led us to a way of improving the drugs. And our hope now is to take it through to clinic, and instead of getting a 20-30% response rate, we should be able to take that up closer to 80% for our patients. Well, initially, the impact that we hope to have is to give pathology a test so that they can decide which patients to treat and which patients to offer an alternative therapy. And the money that would have gone on the cetuximab and the time, because these patients need all the time they can get, they're advanced care patients, can be used in other ways to then allow them to survive, which is our main aim, is patient survival. On the further run, not only should we be able to increase the efficacy of these drugs in the patients who respond, we're hoping to turn non-responders into responders. And we're not just stopping at cetuximab in head and neck cancer. We're working with other groups within the building now, and we're trying to apply the same method to rituximab to kill B cells in leukemia, and Herceptin to kill triple-negative breast cancer, which at the moment is the non-responsive breast cancer. And our other main target, and where cetuximab is already used, is in metastatic colorectal cancer. So we're really trying to hit those cancers that, as people know, are still not the most successfully treated and the hard ones, and that's what we're hoping to do.